do it.
Yep, we're recording.
Great. So just while we give a few more minutes for people to stream in, I heard from a few of you already. If you want to use the chat box, you can put your name in, your organization, and if there's anyone else in the room with you, please let us know who else is joining you today. Hey Ray, did you have any interest in trying to test your audio?
Good morning.
Morning. Hey Alex and Vicky, good to have you this morning. Okay, well, I have a couple minutes, 2 minutes after the hour, so I think why don't we get started? And there might be a few others that are streaming in throughout the early morning. So welcome back for many of you. If this is your first session, my name is Christina Clark. I'm an improvement advisor and change management consultant working with the Center for Collaboration, Motivation, and Innovation. They're not-for-profit that seek to develop helping relationships and improvement capacity. And we're working in partnership through the sponsorship, generous sponsorship with NCACH, who's sort of leading this learning activity. So this is the second session of the 4-part series of Introduction to Quality Improvement for members of the Transitional Care and Diversion Interventions Improvement Project. And I'm really happy that many of you came back. So hopefully we didn't lose you last week. I just want to start with a little bit of a recap from last week. Last week we started with an introduction to quality improvement. We talked about background and the context under which quality improvement in healthcare emerged. Then I introduced the model for improvement and we talked about some of its core components. Today, we're going to take a closer look at measurement for improvement, including setting up the measurement systems and techniques that you'll be able to use to interpret your own improvement data as you're collecting it and beginning to process it. And for those of you that have been following the syllabus, we've shifted slightly from the original plan, but do plan to cover all of the topics by the end of the 4 series. We're just sort of adjusting the content flow as sort of things emerge in the group. And as a reminder, these sessions do build on each other. So some of the previous content will be important to understanding the content we'll address today and so forth. And if you haven't had an opportunity to, or if you weren't able to join the last session, they are being recorded. So you can take a look at that. And John, where are we storing those recordings or sharing them?
I'm going to post them all on the healthcare communities page, and I'll take a snapshot of where you guys can find them and send them out after this so everyone can see where they're posted. They're going to be under a folders document page, but I'll send an email so everyone knows where to find them.
Great. And not surprisingly, then we are recording today's sessions, just for everyone to be aware of that. So we've already started with introductions. Let's see, in the chat box. So if you haven't already, if you can just include your name, your organization, and if there's anyone else in the room with you, if you can add their names as well, that would be great. Helps us get to know everyone and make sure we're not missing anyone. So as I mentioned today, we're going to really dig into the measurement for improvement. But first we'll start by resolving any questions that may have emerged from the last session. Then we'll move into describing the principles of measurement for improvement. So that might be a bit of review from last session. And then looking to identify strategies to measure improvement projects and gather tools to interpret improvement data. So we're going to get really concrete today about measurement for improvement. Tracy Miller's here, who's going to share a little bit about their process for defining measures. And I'm hopeful that everyone will be able to sort of share their own process, because I know there's lots of experience in the group as well. So just coming to a bit of a review from last week, I want to highlight from last week the model for improvement. This is really the key model that will be useful to you as you continue to plan for improvement, measure improvement progress, as well as when we start talking more about testing changes and implementing changes. And recall, this model was developed by the Associates for Process Improvement, and you can find more of the model in the book, The Improvement Guide by Langley and al. It's based on the work of a number of leading thinkers in the disciplines of management theory, statistical theory, psychology, and underpinned by the theory of profound knowledge, which we talked about last week, developed by Deming. So there's the three key questions that are included in the model for improvement. What are we trying to accomplish? How will we know that a change is an improvement? What changes can we make that will result in improvement? And remember, the first question is answered by our concrete aim statement, and we use the acronym SMART: specific, measurable, actionable, realistic, and time-bound. Then we talked briefly about measurement, so that's the answer to the second question, and some of the principles behind why we want to measure and how we measure for improvement. We're going to dig in today more in that specific question topic. And then third was, what changes can we make? And that's really just the changes, followed by the PDSA cycle, Plan, Do, Study, Act cycle. And we're going to talk a lot more about that next week. But start a little bit thinking about some of the changes that you're hoping to test, which was the question we left with last week. So before we continue, are there any questions that popped up from last week's session? Anything you have on your mind? Nothing from last week. Okay. So if there's nothing from last week, we'll probably check in at the top of each of the sessions to make sure if there's any questions you have from the previous session that we can address those. Of course, you can always reach out to me if you have any questions about the content at any time, and I'm happy to have a conversation with you. So the question we left with last week was, what is the one change idea that you want to try using a PDSA cycle? And we're going to talk a lot about PDSAs next week. Again, we're going to focus on measurement today, but I just kind of want to get sort of the gears moving in terms of thinking about what are some of the change ideas that you want to try using a PDSA cycle. So what did you come up with?
Can I ask? I know a number of people listed change ideas in their original quality improvement charter. Have you guys had a chance to test any of those out since you developed that charter? And I know we've had some conversations. I'm going to pick on someone here quickly that I can. I'm looking at Cooley Medical Center. I know we've had a number of conversations on the transitional care management process, and I know you guys have made some adjustments since you originally started that. Do you know how you guys went through those processes? Or did you do a PDSA on it?
This is Kelly Steffens. I didn't do a PDSA. I just kept revamping it each time I did a training or read something different or realized what I was doing was not working. So it was like a PDSA.
Yeah,
we just didn't write it down. True. Okay, yeah. So PDSA in my mind.
And Tina, that's a good question. I feel like PSAs have to be written down, or it seems like they kind of organically happen, right? What's your guidance on that? Does it have to be more structured?
Sorry, I'm just stopping my video because it's cutting out a little bit. I'm not sure if it's you, Caroline, or me. You know what? Depending on who you ask, you'll get a totally different response, not surprising. Some people are very disciplined and very committed to the discipline of documentation for a PDSA. And I think that can be good as long as it adds value to your process. Other people are much more flexible in terms of, once you become really sort of experienced with or facile with using a PDSA cycle, a lot of this stuff does happen in our minds, right? The only risks of not documenting it are that if we proceed using it with a change and we adapt it over time and then ultimately implement it because it's effective, we risk losing a lot of the knowledge that we gained in learning from it and being able to adapt it in other settings. So it's just sort of, there's, documentation in principle is useful to be able to share, useful to be able to track what we've done and why it worked. But yeah, you got to balance that with how much it slows you down when it comes to documentation. I think one of the most important points about documenting a PDSA cycle, and we'll talk a lot about this next week, is that you're making clear, you're at the very least documenting your prediction. So what do you predict will happen and what actually happened is probably the most important piece, because it's the part that contributes to your theory building and your learning over time. So that wasn't really much of an answer. It depends. What changes are others thinking about?
Can I ask for other individuals? I know one of the measures we'll probably talk about at some point is follow-up measures. I know some organizations have looked at how that works internally to your own primary care clinic versus externally. Has anyone looked at processes or evaluated processes on how that gets done? And Vicki and Alex at Columbia Basin, I know these were discussions we've had at some point. Have you guys had a chance to look at how you do follow up within like Columbia Basin Family Medicine versus the outlying clinics?
This is Alex. Vicki abandoned me for a minute, but this is actually my second day on the job. And coming from the ED, I know follow-up wise, we've been, we'll follow up with patients by phone the next day if they're not from Columbia Basin Family Medicine. Columbia Basin Family Medicine has started following up with their own patients, and we follow up with everybody else. And then we've also been trying to establish follow-up appointments for patients if they have a local doctor. And we're having a bit of trouble getting feedback on if patients are actually going to these appointments. So that's something we're looking at and working on.
Is that, Alex, is that getting the data on whether it actually happened, or is that feedback on whether it was useful, or both?
It's more documentation like on if the patient actually showed up for the appointment.
Right. Okay.
And then just talking to patients when we tell them we made a follow-up appointment for them, it's been mixed. Some people are really grateful and are excited by it, and some people are annoyed, like, I can make my own follow-up, leave me alone type deal.
Okay. So I think that's something that's a common challenge in terms of tracking that data. And we're going to talk a little bit, really high level, about sampling techniques that might be helpful for that. But I'll be interested in hearing more about that when we get to that point. Others, changes you're hoping to try in the next week or two?
Christina, this is Tracy at Mid-Valley.
Hey,
and
Tracy.
I think, you know, when we first started doing or hearing and really, you know, trying to delve into PDSAs, we kind of looked around and went, oh my gosh, one more thing to do. But, you know, when you stop and you think about it, we all are doing it. We just didn't really put it into the format of the PDSA. I mean, none of us, especially in healthcare, start with an idea and go, oh, it didn't work, scrap it, let's move on. You know, I mean, we all look at a process and go, this needs improvement. This is, you know, this is how we're going to do it. And so we just do it, you know. And I know for us here at Mid-Valley, we're very informal with our PDSAs. You know, like somebody said, it's all in our minds. You know, this is what we've done and moving on. But I think PDSAs encompass a large portion of all of our jobs and our roles, especially with the change management that we're doing with the ACH. I think that we just don't put the PDSA name to it.
I totally agree, Tracy. I think that's a great point. And something, Kelly, I think you mentioned as well, is that the PDSA is really intuitive, especially in a healthcare setting, because it's really just the scientific model of hypothesis testing. We come with an idea that has a pedigree, some evidence, or local experts develop an idea, and we seek to test it out. When we think about PDSAs, there are some techniques that we can use to sort of refine our abilities to do this, but I totally agree that it comes very naturally to this group. So you're doing it all the time. So with that, I think I'll move us into the content on measurement for improvement. And again, we're going to come back to talking more about PDSAs next week. And we'll talk more about change ideas you're trying, how they're working, and how some theories and some ideas for testing them. In terms of PDSA cycles, one of the challenges, especially when we don't connect it to a plan, or maybe we're doing it in our head, is that it can get really big. So part of the PDSA cycle is breaking it down, knowing when to scale up, and knowing when to implement, and we'll cover some of that content next week. So like I mentioned, we're going to drill down into measurement for improvement today. We started to talk about measurement for improvement last week, and talked about principles of measurement for improvement. We differentiated measurement for improvement from other measurement purposes like research to create new knowledge, accountability for choice. We said measurement for improvement is really concerned with just enough, good enough data. We're not looking for perfection in our data, but we are looking for data that will help us learn and improve and won't slow us down. So there's a balancing act with measurement for improvement. We're going to talk about this in terms of a process today. So these are some of the practical details of measurement. Many of you have already set up and reported measures for your projects, and for you it might be familiar. And so I'm really keen, I think with this group we have a lot of knowledge already, and sharing that knowledge across all of these tables will be really helpful to all of us. So as I move through this, don't hesitate to use the chat box to include some of the comments and experiences that you've had and your expertise, or just interrupt me and give us some examples. So here's some of the general steps in the process of measurement. The first is to choose your measures. The second is to define those measures. The third is to collect them. And 4, finally, to learn and act. Because we're not just here to measure, we're here to take action based on what we're seeing in our measurement. So breaking down each of those, the first step is choosing measures. And when we think about choosing measures, some of the things we like to think about are, how can you align the measures with your aims? So if you want to improve the rate of primary care provider follow-up, you'll of course also want to be measuring what is the rate of primary care provider follow-up. We also, when choosing our measures, want to think about our principles of measurement for improvement. So useful data, not perfect data, just enough, good enough data. And for most quality improvement efforts, just a small number of measures, 4 to 8 per topic area, will be enough to know if the system is improving. You do want to be careful that you're not collecting too many measures, which can create measurement burden, or choosing measures where it's impossible or really difficult to get that data. Now, there are situations where we really want the data and it is difficult, but we feel it's important enough that we want to overcome that hurdle. And in that case, you might want to think about using a sampling approach. So you don't always need to collect 100% of the data. You can use a sampling approach. And when I say sampling, I'm not talking about the research version of sampling with confidence intervals and all that stuff. When I've spoken to statisticians about sampling and improvement, they remind me that the principles of measurement for improvement apply. Useful data, not perfect data. When they speak about sampling, they say it's really about trust. Just having even 10 cases is probably all you need. So if you're thinking about stuff like following up with external organizations to understand whether patients are showing up when they have their follow-up appointments, that could be a good instance for using sampling, because it's not always feasible. You don't have the integrated data systems to be able to just have that straight from your EMR. In quality improvement, we also recommend setting up what we call a family of measures so that it's also what we call balanced. And really what that means is that you have a good cross-section of outcome, process, and balancing measures. And you may have already come across these different types of indicators or measures, but I'll just go through each of these 3 types with a couple of examples. So outcome measures are pretty intuitive. They're the endpoints or desired endpoints of processes. Some examples of outcome measures might be patient experience, or plan all-cause readmission, the number of patients with 3 or more ED visits in a calendar year. So outcome measures are typically framed within your aim statement as what are you really trying to accomplish, and that's often what the outcome is. Process measures are the steps or the tasks in a process that are required to achieve an outcome or outcomes. So examples of process measures could be follow-up after hospitalization, the percent of patients receiving TCM calls. And then finally, balancing measures is one that, that sometimes is a little less known. And essentially what it is if you're changing parts of the system, you want to have some sort of mechanism to be able to understand if it's having any unintended consequences to other parts of the system. So an example of this that's usually pretty easy to understand is that if you're seeking to reduce hospital length of stay, so if that's your outcome measure and your aim, then you might also want to take a look at readmission rates to see if those are also going up, because that could be an unintended consequence of reducing length of stay.
Christina, can I ask, when you're doing a project, should you have at least one measure in each of those three categories, or is it kind of up to the project and the people measuring it?
I would typically recommend having one, so if you had an aim, having at least one outcome, process, and balancing measure each. And usually it happens naturally. And we'll have an example. It's often really easy to find the process measures, but the balancing measures are sometimes a little trickier, and then outcome measures are also generally fairly intuitive. So let's take a look with an example. So here's an example of an aim statement. By March 2020, we aim to reduce the number of people that are seen in the emergency department 3 or more times in a calendar year by 10%. Okay, so that's the aim statement. And then here is the family of measures that this team put together. So A is patient-reported confidence that the patients can manage their health conditions. B is the number of patients with 3 or more emergency department visits in a calendar year. C is time to perform the TCM call. And D is percent of emergency department visits where patient has a primary care follow-up in 30 days. So probably just using the, let's see, the chat box, or feel free to unmute yourself. Which one of these measures do you think is the outcome measure? Just using A, B, C, or D. Which one of those is the outcome measure? So B, we got an A, a B. Any others? So when I take a look at the aim statement, we aim to reduce the number of people that are seen in the emergency department visit 3 or more times in a calendar year. I think it's probably B that's the outcome measure, because that's the real outcome that we're trying to move based on the aim. So then if that's our outcome measure, and again, you can have more than one, and this can be open to interpretation, of course, which of these measures do you think is a process measure? If there's more than one, just include all the letters that you think are process measures. What do you think? Use the chat box to put in the letters. We got a C, we got a B. What else? What are others thinking? Which ones are the process measures? C, D. Great. D. Awesome. And then does anyone see anything that could be a balancing measure? Remember, the balancing measure is the one that seeks to look for unintended consequences from the changes we're introducing. It could be a positive consequence, it could be a negative consequence. So we have D and A. C, time to perform it, yeah. A. C. Great. Great. Lots of different perspectives on this, lots of different responses. And I think that's important that we show that it's not always clear cut. What is the process? What is the outcome? What might be the balancing measure? It's often a little more obvious what's the outcome because we frame it up in our aim statement. But really what's most important is that you're getting a family of measures so that you're able to sort of look at the system wholly, not just one piece of the system, but look at a number of components of your system that you're trying to improve. So when I think about these measures, I might interpret it, and this is just my interpretation, patient reported confidence that they can manage their health conditions. So if you're trying to reduce the number of people that are repeatedly coming into the emergency department, one of the things you might look for is when people are leaving the emergency department or leaving care, that they have a high confidence that they can manage their health condition. And that's been found in evidence to be correlated with reductions in repeat ED admissions. So that could be a balancing measure, it could be a process measure. And it's nice when sort of the two overlap. Number of patients with 3 or more ED visits in a calendar year B is what I would consider to be, in this case, the outcome measure. It's not the ultimate outcome, which is that we want to have a healthy population. But when we're framing up our improvement project, that's really the outcome that we're looking for. C, time to perform TCM call, could be a process measure. It could also be a balancing measure. And it becomes a balancing measure if some of the processes that we're seeking to introduce, some of the changes we're seeking to introduce, if they're taking a really long time, so if we see the time to perform this care is taking really long, it's probably not going to be sustainable. So in that case, it can signal to us that we're having an unintended consequence, and in that case, it becomes a balancing measure. And then finally, D, the percent of emergency department visits where the patient has a primary care follow-up is probably a process measure as well. Anyone any other perspectives on that? Any questions that you might have about that example?
Tina, for some reason, I think of D as an outcome, because that's ultimately what you're trying to do, is connect patients to follow-up care. So can you talk me through how you think of it as a process measure?
So when I think about outcome measures, I think about them in the context of what do we really want for patients? And it's not the processes of care. It's not that they have follow-up necessarily in 30 days, but it's that they're living more healthy lives. It's that they have the resources they need to take care of themselves. And ultimately, it's usually framed up in terms of morbidity, mortality, well-being, those types of things. So percent of ED visits where a patient has a primary care follow-up in 30 days is hopefully a process in that journey for best or for whole person care. Does that sort of make sense? Okay, good. Any other questions? Okay. The second part in our measurement process is defining our measures. So once we've chosen the measures or selected the measures we want. We have a balanced set of indicators that reflect on our aim statement. What we then look at is defining them. And there's usually 3 components to defining a measure. The first is our conceptual definition. This is what we most often see. It really just describes what the measure is, the concept or the construct. The second piece is the operational definition. That tells you how to measure it. So what data is involved in it? What calculations are we going to use? And then third is the collection plan. Again, this one elaborates on how are we going to measure it. So who's going to grab the data? What are they going to do with the data? How are they going to do it? And how often are we measuring and abstracting data? So let's look at this with an example, and Tracy is going to provide us a little bit of an exploration into their process. So Tracy, I'll hand it over to you. I'd love to hear, how your team aligned your measures with your aim, and if you can maybe just pick 1 or 2 to describe operational definitions and your collection plan, that'd be awesome.
Thanks, Christina. When we first sat down, what has it now been, 2 years ago, when we first sat down, we were kind of deer in headlights about what do we put down? What is the expectation from us? And then we kind of overthought it and kind of just took all of that away and said, what do we want? What do we want to provide our patients? And we sat there and we just listed a bunch of different goals. And some of them were short-term goals, some of them were long-term goals. And then the next process was just, how do we get there? And, we had different people on the team, and so they gave us different ideas of how we get there. We had people that are doing face-to-face patient care every day. We had somebody from operations. We had somebody from IT. And so there was a lot of different input in how we get there. And, one of the things was, okay, so we're done, right? We've got it down. We said how we get there, let's go. And then it became, oh no, how do we know when we need to take the next step forward? What do we do if we go backwards a step? And so, part of that process was the PDSA cycle, like what you were discussing. And so that really helped us out in terms of, okay, so we're not doing great here. What can we do to flip this and try something different? And after we had that general goal, we kind of broke it down into a SMART goal. How specific, measurable, achievable, relevant, and what's that time frame that we want to get it done in? And so that really helped us to kind of come up with our numerator and our denominator. And we also took our CAP survey. We're with an ACO, and so we get our annual CAP survey. And, we wanted to see what the patients were saying. What was their complaints about us? Not just what we were doing good, but what did they feel like where we needed improvement? And so we took all of that and kind of, some days I feel like we put it in a Tupperware bowl and shook it up like a taco salad. And then, some days I feel like we sat there and we picked out the tortilla chips because those are the best part of the taco salad. But, we really looked at it from a bunch of different ways, and I don't know if we did it right. I don't know if we did it okay. It's still an evolution. Yesterday I had a discussion with several people about, hey, our numbers, I'm seeing a trend here. And I don't like where this trend is heading, and that's part of looking at your numbers as well, and making that continual improvement. And even though you're 6 months down the road, you may have to make those changes. And so one of the big things that we wanted to focus on here for our transitional care was that our ED patients that did not leave AMA, we had to kind of be specific there, that did not leave AMA or left without being seen, but the rest of those patients, we wanted them to be contacted by one of our transitional care nurses within 48 business hours. And not just to be contacted, but also to perform a reconciliation in our EMR with what was done in the ED, whether that be medications, diagnostic studies, new diagnoses, anything like that. We wanted that in our system. And so that's kind of been spearheaded in a way that really kind of makes it close to my heart, because I feel like those are our patients that have the least follow-up. You know, they go and, you know, you kind of become jaded after a while of, oh, they've gone to the ED, you know, 5 times, you know, in the last 6 weeks. What is going on? Oh my gosh, can't they figure it out? Into turning it where, okay, so why are they going to the ED? You know, are we not doing a good enough job of explaining, you know, things? Are they not understanding their healthcare condition? And so it kind of, that one measure broke it out into a lot of different little things for us. And so, and we've actually seen where our patients that get that TCM call, you know, we're able to get them in faster, where before, you know, they were hopefully being seen within 30 days. And now we've really shown that the majority of our patients were getting in to follow up within 7 days, you know, to kind of close that care gap, or that care loop, sorry, and provide better patient care for our patients. I wish we could do more with more EDs throughout our community, but we're kind of stalled at the moment with everybody's EMRs. So we're hoping to get pre-manage in so we can see more about where our patients are going and provide TCM for those patients that may be going to Wenatchee, or maybe going to Yakima, or maybe going to, you know, Cooley. And so continual process improvement, right?
Thanks, Tracy. Did you have, I love how you described that you started out with, what do you really want for your patients? And that's the first question in the model for improvement. What do you hope to accomplish? And you looked at your team and what did they want to accomplish? You did a brainstorm. You also looked at what your patients were saying to frame that up. And then from that, when you were really clear about what standard you wanted to provide and what you wanted to accomplish for your patients, you started thinking about how you would measure that. And so this list, for those who aren't familiar, I took it directly from the Excel spreadsheet that all of you have for your measurement in this project. Tracy, were there any challenges that you had to overcome in terms of setting up your measures or defining your measures?
My coworker here goes, not a single one. And then started laughing. He's our IT analyst that was part of this from the get-go. And so, you know, yeah, there was a lot of process. You know, there was some, you know, that we really wanted to measure, but we were very limited by our EMR. You know, we just can't extract that data. Mm-hmm. And, you know, so that felt very defeating for us, because it was something we really wanted to do, but we just don't have the technology for it, you know. And then trying to get everybody to buy into the process of, you know, here we are, we did not have a provider on our initial team. And so trying to get the buy-in of providers was huge for us. You know, it's like, you know, and I always kind of joke that providers are like, how many more clicks do you want me to do? How many more boxes do you want me to check? And they kind of approached it with, great, this is more work, this is more boxes, this is more this, more that. But once they actually saw our patients and how this was affecting them and what a positive thing it was for them, the buy-in just came naturally and very, very smoothly, I must say. I was kind of surprised by it. I expected more resistance. But, you know, I think we all have those difficulties that we kind of have to overcome. But for us, it was very, I don't know, it just worked out where we didn't make excuses. We just kind of did it anyway, other than the EMR, because we can't fix that. But and we just kind of, some days I feel like we bowled over people. I know that's not appropriate to say, but I feel like it was like, hey, we're doing this for our patients. If you don't like it, tough. Deal with it. And so, you know, that's probably not the way to do that, but you know, it's worked out very well. I can't even talk. It's worked out very well. So most of our staff are really pleased by it. It's taken the load off of the day-to-day nurses that are doing face-to-face patient care, so they don't have to put that information in and reconcile that chart. Somebody's doing that and making those appointments. And so, you know, those people that didn't want to do it initially now are seeing the benefit of it.
That's awesome. And we're going to talk a lot about change management and some of the strategies. You said you potentially bowled over people, but it sounds like you used actually quite a few strategies to make the change easier for people, which means it's more likely to be adopted. So we'll come back to that for sure in our fourth session, talking more about change management. Thanks, Tracy. Any questions? Any questions for Tracy? Don't hesitate to use the chat box too.
Tracy, this is John. I'm actually just going to ask, I'm curious, are all of your measures pulled out of the electronic health record system? And or did you go through a process to determine if you were going to track a measure manually, the worth to do the manual work versus the value you get out of that measure? Does that make sense?
Yeah, no, it totally does. It's very great with having, you know, the hospital, even though the hospital's on one EMR and the clinic's on another EMR, we do have kind of a pipe that goes between. And so their information will flow down to us. And so that helped a lot, but a lot of it is manual. And so I kind of had to look at it kind of as an overall project and say, how can I combine a couple of different methods? And so, like, for example, for our ED visits, we actually get a daily list from the hospital that actually has all of our admissions, discharges, and ED visits on there. And so I go through those at the end of the month, and I kind of, it's a long process, but it really isn't. It really is pretty fast now. But I go through and I have to go into the hospital system and assign a level, like a prophy level, for unnecessary ED visits. And then I go into each chart, and granted, we're only talking like less than 80 a month. So we don't have a lot of these patients that are on this list. And so I then go into each chart and make sure that the patient was called in 48 hours, and then making sure that they have a follow-up. And so I kind of do it all at once with a lot of different measures, so I'm not repeating the work. And so, but a lot of it is manual, unfortunately. We're hoping to change that, though, when we go to our new EMR.
Thanks, Tracy. Okay, I'm going to move us forward, but I'm sure more conversation to come. Feel free to use the chat box, and also we'll come back to some of that with changes in our next session. So just to recap about, let me actually just go back about our conceptual definition, operational definition, and collection plan. When it comes to defining measures, in this particular example on the left, name of the measure, that's really where the conceptual definition is. Percentage of patients discharged from inpatient receiving a TCM call is an example of a conceptual measure. The operational definition includes the numerator and denominator. And then a collection plan would include more detail. So who's gonna grab that data? How are they gonna process it? Where do they pull it from? Is it manual? Is it from the EHR? So some of the things that Tracy described, when is it going to happen, on the last day of each month, kind of thing. So in terms of setting up and defining your measures, having an operational definition and a collection plan makes sure that you're measuring the same thing each month, each period of measure. The third step in our measurement process is collection. So this one's pretty easy. Collect the data regularly and consistently. Make sure you're following your operational definitions and collection plans. And data over time is the ideal to visualize variation in our processes. We'll talk a little bit more about that, starting with a case study. But we're moving into now, what are we doing with our improvement data? Now that we've chosen our measures, we've defined our measures, we're starting to collect them, which is where everyone is at right now. How do we interpret what we're seeing? So here's another case study example. By January 2020, we aim to reduce 30-day unplanned all-cause readmission by 25%. So let's take a look at this fictional data. Say our improvement team measured their 30-day unplanned all-cause rate in August 2019. So we're already talking about the future here. But on the left of with this bar chart, we've got 20% in August 2019. They label it the baseline because it's their first measurement period. They're using the model for improvement. They set their aim, set their measurement infrastructure, begin testing and implementing changes to improve their rate here. And then they measure their progress again in January 2020, so about 5 months after they started, and find their readmission rate is 15%. So that's down from 20% in August. So when you take a look at this, what do you think? Do you think that this team made an improvement? And I'm just going to pull up a poll. What do you guys think? Do you think this team made an improvement based on these results? So just 10 more seconds. Okay, let's see, share results. So do we think this team made an improvement? Can everyone see the results? Someone look? Yeah, okay, good. Okay, so did the team make an improvement? Looks like a little over 80% thought, yes, the team did make an improvement. And about 17% thought, I'm not too sure if they made an improvement. So let's take a closer look at this case study. So we've got the data point in August, we've got the data point in January. It looks like an improvement if we take a look at the 2 points. But let's take a look at some scenario that this data could also represent. So here's the first scenario. And this one shows no improvement. So again, it's the exact same data on the left as it is on the right. There's not really, when we look at the data on the right and the time series chart, or what we call a run chart in improvement, there's not really any improvement, it doesn't look like. There's just a bit of variation in there. And so this phenomena really is only observable when we take a look at this data over time, rather than looking at 2 data points, looking at data over a period of time. And the risk is that if we only take a look at 2 data points, we can come to some errors in our conclusions and actions. Because this could also be our results. Again, it's the exact same data. In August, we have 20%. In January, we have 15%. But this one actually looks like we did make an improvement starting in August. But that potentially that improvement wasn't sustained over time. So maybe we let our foot off the gas, or maybe our processes weren't as standardized as we'd hoped they would be. So again, if we didn't take a look at this over time, we might not be aware that we did in fact make an improvement, but that improvement wasn't sustained over time. A third scenario is improvement. So same data again, in August 2019, we have 20%. In January 2020, the same measure, we have 15%. But this data in a run chart here looks like we've actually made an improvement. So my point, really the key message here is that data over time is the ideal to look at the systems that we're trying to improve. If we just look at 2 data points, it's really difficult to determine whether it's normal variation or whether it's an actual improvement. So what we want to do in improvement is to look at our systems with run charts. So the key takeaway is that time series data is really important in improvement. The simplest and most common tool that we use is the run chart. It's a universal tool for every improvement project. It helps to make our variation visible. It's a tool for learning about our processes. So how much variation is in our process? Historically, have we had improvements? Historically, have we seen declines in our performance? It can also assist us to identify signals of improvement, and more on this, and assist us to identify if we've sustained that improvement over time. So very simply, this is a run chart. It's really just your data over time. Usually we use time on the x-axis, monthly, quarterly. We plot our observations on the y-axis. So in this case, we've got missed appointments per month. And then what makes this a run chart is when we take every observation. So here we have 4 observations, 20, 30, 20, 30. And we calculate a median line. So not the average, but the middle value or median. And we plot the median line. And that's what makes it a run chart. And what's great about these run charts is that there's some statistical tools that we can apply to analyze our improvement data. So these are probability-based rules. What that means is if you flipped a coin 100 times, you would roughly expect 50 heads, 50 tails if there wasn't any problems with the coin. To be able to apply these rules, you do need at least 10 observations, which is why sometimes using monthly data helps to accelerate the observation of improvements or detection of signals of change. But you can do this with quarterly data. It just takes a little bit longer. And it's used to identify signals of improvement, or to get technical, signals of non-random patterns in the data. So you wouldn't, absent an improvement or absence of your involvement in changing the process, you wouldn't see this data. And so these are, I'm not going to read them all out because we're going to have an exercise that's going to follow this up so that you'll be able to apply them. These are the run chart rules. So these are the rules to detect if you have signals of non-randomness in your data. It'll become a lot more obvious when you do work through the process. I've had feedback that run chart rules are annoying, and they are annoying because they're just rules. We just follow the steps and apply the rules. And over time, the more you practice applying those rules, the easier it becomes. But again, these are things that you can use to make conclusions about your data that you've actually made an improvement. You can use these run chart rules to publish in quality literature to show that you've made improvements. So they're really handy to have, but they're not something that you're really going to be able to use until you have about 10 observations with your data. So more on this when I send out a handout following up on this call. We'll get an opportunity to practice interpreting some run charts. So that was pretty high level on interpreting your data. Are there any questions before we close out and do an evaluation?
Tina, this is John. I know for the TCDI, we're collecting information quarterly. Do you encourage people to track monthly, though, internally? Or
I mean, I do in the sense that if you're working on your improvement, that it gives you a better sense of that improvement over time more quickly. And so you're able to respond to it. The reporting and monitoring are 2 different things, right? You can report less frequently, but you can monitor or take a look at your data on a monthly or even sometimes use weekly basis. Again, it goes back to balance of burden and value. So how much time are you spending on measurement versus how much time are you spending on patient care and improvement? And that's a team decision to make. So again, don't hesitate to reach out to me by email if you have any questions about any of this content. We'll also come back to it at the top of next week. So if there's any outstanding questions as you're thinking through measurement for improvement, how it's going to apply to your work, we'll have an opportunity to check in then as well, because we didn't have a lot of time for questions. I'll send out after this an email with that run chart exercise. It will include all the list of rules and how to apply them. But again, if you have questions as you're working through it, reach out to me. And finally, I'm just going to pull up a quick evaluation for today to get your feedback on how today went, whether we're on track. And whenever you're done that, feel free to break off. Thanks very much for joining today.
John, this is Rhonda. I have a question for you. For the website, does everyone have access to that now, or like my team that doesn't, can I send that to them and they can register on it?
Yep. I would say you probably have access yourself from North Valley because I sent you an invite, but I'll make sure. Are all the names you put in the chat function people you want to have access to it?
Please.
Yeah, I will connect with you after this to make sure that your whole team has access to it.
Okay, good. That way, because that's where the recordings will be for our training, right?
Yep. And
So
I'll do that. I'll do that for everyone if everyone is okay with that. If there's any objections, let me know, but I'll try to make sure that everyone who's attending these calls have access to the online site.
Thank you, John.
You're welcome. Thank you all.
I've just noticed that I failed to edit the learning objectives for the evaluation. I'm sorry, that was my bad. I'm just going to put them into the chat box now. So we'll just focus on these two as the learning objectives. Oops, I sent that to Caroline. Thanks again, everyone. Feel free whenever you're done the evaluation to carry on with your day. Really appreciate your participation today and reach out if there's any questions.